Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual, and today some more important clinical care tips that hopefully will help you take care of your patients. Rule number 215. Be the opposite of your psych patients. Now, I apologize in advance if that rule sounds insulting to anybody. I would like to explain. So, unfortunately, as we all know very well, the amount of children coming to the pediatric emergency department with psychiatric presentations, unfortunately, has increased significantly. Dr. Victor Fernari, a pediatric psychiatrist in Long Island, specifically spoke about it in my interview with him on one of the episodes of Pen Rules. I encourage you to listen to that episode. And we think maybe the trigger is COVID or some other trigger, we don't really know. But there's no doubt that the amount of children with anxiety attack, depression, and suicidal ideation intents has significantly increased in the last few years, for whatever the reason is. And over the years, I think we all had that experience that every once in a while, the pediatric patient in the pediatric emergency department becomes very agitated, very angry. Sometimes there is some verbal language that we can talk about right now. Sometimes we have to restrain the patients with chemical restraints being Versed or Ativan or Halidol, and sometimes I have had to physically restrain those patients. It doesn't happen very often, but it is unfortunately a real thing. And one of the advice that I got from Dr. Fernari and other psychiatrists is in those situations to behave exactly the opposite of what the patient in front of me is behaving like. So if the patient in front of me is screaming, yelling, cursing, angry, agitated, I have to be at the edge of the room, at the entrance for my safety, but I have to speak very softly, very calmly, sort of forcing that patient to listen if he or she want to hear what I'm saying. I think our demeanor as physicians, especially when the nurses, the medical students, and the residents are looking, is very important. It is very easy to get into the same mood and argue and scream and behave unprofessionally. But I think if the patient in front of us is seeing what we speak like softly, calmly, kindly, hopefully that can help de escalate the situation. Same thing for the patient with anxiety attack. He or she are tachypnic, worried, anxious, maybe even agitated. Again, the mood should be calm, cool, collected, kind, and professional. And by doing so, maybe influencing the patient to behave the same. And I guess, as always, this is always easier said than done. It is very easy as the physician, after 8 or 9 hours in the pediatric emergency department, to get angry and yell back and even behave unprofessionally. Sometimes it's really hard to control. However, I think it's really important to really be the opposite of what the patient is. So for the patient who's agitated, to be calm. For the patient who's screaming or speaking very loudly, speaking very softly, etc. Again, as in the past, easier said than done. Rule number 216. Empower the parents. So I never fault any parent for coming to the pediatric emergency department. Any parent who is worried, and I tell them that all the time, if you're worried, you should come and see me. As a parent, I don't recommend sitting home worried and looking up things online and finding some unrelated information that will just unnecessarily worry you. If you worry, come and see us. Having said that, I really do encourage the parent to be a little bit of physicians or nurses or clinicians. I certainly recommend coming and see us if you're worried, as I said, but I certainly give the parents some parental skills that I want them to have, so hopefully they don't worry unnecessarily next time. I think the best example for this is the patient or the parent who comes to the pediatric emergency department with a fever, especially the newborn who presents with a fever. So I think all of us have had that encounter when the parents bring a 2 or 3 or 4-week-old with complaint of a fever and the parents did not obtain the temperature rectally, which is really the only way you should obtain temperature in a newborn. I think we all know the septic rule out or the full septic workup in a newborn is a little bit of a big deal, and it's not something I want to do unless the patient truly needs it. Now, that's a whole different discussion. I think for the most part, the evidence have suggested that if the patient was febrile in a medical facility, let's say the primary caregiver, he or she are truly febrile, even if they're not febrile right now in your ED, and the recommendation is to do the full septic workup. But many times I've seen newborns coming to the ER with normal temperature, and the parents who obtained the temperature with a forehead thermometer, for example, did find temperature of 100.4. I think in these situations, I usually observe the patient for a very long time after a good history and physical. I don't necessarily do a full septic workup, but I ask the nurse to teach the parents how to obtain rectal temperature. And I ask the parents to do that the next time, and I try to explain to the parents that unfortunately, in a newborn, although it seems a little abusive, that is the only way to get a true temperature. I don't recommend we do a full septic workup on a patient where the temperature was obtained in the forehead with the forehead thermometer or any other way except for rectal temperature. So I try to give the parents some tools and I try to empower the parents to be a little bit of a clinician. My other example are the parents who come to the pediatric emergency department with a rash. That is, again, very, very common. I don't know what it is about rashes, but rashes really do worry some parents. Many parents have a very low threshold to come to the pediatric emergency department because the child has had some kind of rash for a few minutes even. So again, I try to empower the parents and give them some clinical tools. I very often demonstrate to the parents how to stretch the skin, so to speak, when they see red rashes on the child. And if the redness disappears, that's usually not a serious rash. Obviously, I'm talking about testing the patient for blenching rash, and I'm talking about the rash that doesn't disappear or doesn't blench, being petechia or purpura, that is a little bit of a red flaggy sort of symptom. So I usually tell the parents every time your child has a rash, rashes in kids are usually red spots, feel free, mom and dad, to stretch the skin. And if the redness goes away, that's usually a good rash. In other words, that's usually a mild allergic reaction or maybe even something related to a viral infection, but that's not a serious rash. If your child ever has red spots that when you stretch the skin does not disappear or does not change, that's blood underneath the skin, and I want you to come and see me. Of course, I'm talking about some petechia or purpura. Again, I'm talking about giving the parents some clinical skills so they don't worry unnecessarily and don't just come to the ER. Another good example are the parents who come to the pediatric emergency department since their child is constipated. I very often make sure parents are aware that enemas are very effective for constipation and are over the counter treatments that they can buy at the store and they can administer themselves. So I very often ask the parents, or ask the nurse rather, to teach the parents and show the parents how to give an enema. Enemas are safe, can certainly be given at home, and there's a reason they are over the counter. Again, if the parents want to come to the ER to get an enema, that's okay with me, but I try to empower them and teach them some clinical skills for something they can do at home. Essentially, an enema is no different than Tylenol or Motrin. So if you want to come to the pediatric emergency department because your child is constipated, that's totally fine. But I truly recommend if your child is very constipated to at least try an enema at home. And if that doesn't relieve the pain, by all means, come and see us. Rule number 217, relate to the patient. So obviously, I don't fault anybody out there who is a pediatric emergency doctor or a pediatric emergency provider who doesn't have kids. But I truly do believe that when we have our own children, that does make us better clinicians. And I think parents really appreciate when we relate to them as parents. So one of the things I find myself telling to parents all the time is, Mom and Dad, if this was my child, so and so. So I think many times, as you probably know, I meet parents who are very worried about their children, be it for the fever or the rash or whatever symptom he or she has. I think telling the parents something like, Mom and Dad, I happen to have a child of my own that is about your child's age, and I gotta say, if this was my child, I wouldn't necessarily worry. I think parents really appreciate that you relate to them as a parent and not just as a clinician who's in a position of power. On a different note, I often meet parents who want to leave AMA or don't think their child's presentation is particularly severe, and I don't share the same feeling. I often find myself saying something like, Mom and Dad, I know you're not worried and I know you want to go home, but I gotta say, if this was my child, I would have stayed in the emergency department for a few more hours or maybe get admitted just to make sure everything is moving in the right direction. Sometimes the parents are reluctant to do any testing, blood tests. Again, saying something like, if this was my child, I would have want to make sure everything is okay. Let's just do those blood tests to make sure. Again, I think parents often appreciate when you relate to them as another human being, so to speak, as another parent, and not as someone who's in a position of power and making decisions. So remember rule number 217, relate to the patient or relate to the parents. My last example for this rule is those patients who unfortunately get antibiotic, in my opinion, unnecessarily. So every once in a while, I see a patient that was diagnosed with pneumonia clinically and was prescribed antibiotic for 10 days when he or she really just have a virus. I often tell those parents, Mom and Dad, if this was my child, I would highly recommend that if you worry about pneumonia or if your doctor is worried about pneumonia, come to the ER. We can do an x ray and say almost definitively if there is pneumonia or there isn't, and we will give you antibiotics if the chest x ray is positive. I don't recommend, and again, if this was my child, I don't recommend you give your child 10 days or 7 days of antibiotics based on just listening to the lungs. Getting a chest x ray is very easy. If this was my child, I wouldn't recommend giving them antibiotics without a proof of bacterial infection. Again, I think parents appreciate that when you relate to them as a father. And that is it for today, guys. Thank you very much for listening. Let's briefly review what we learned. Rule number 215, be the opposite of your psych patient. When the patient is agitated, be calm, cool, and collected. When the patient is yelling, speak very softly. Be an example for your residents, for your nurses, and for your patients. Rule number 216, empower the parent. Parents, by definition, have to be somewhat of clinicians. Parents have to know how to evaluate their child and know when to worry. Again, I never fault any parents for worry, but I do encourage them to have some tools, to have some skills in order to evaluate if their son or daughter really need to come to the pediatric emergency department. Again, teach the parents how to differentiate between petechia, purpura, or just rash. Teach them how to give an enema. Teach them how to obtain rectal temperatures. Although those seem like medical skills, they really are also parental skills as well. Rule number 217, relate to the patient or relate to the parents. I think patients and parents really appreciate it when we speak to them at eye level and not just as physicians or clinicians. I find myself telling to parents, Mom and Dad, if this was my child, so and so. I think parents really appreciate when you relate to them on a level they can understand. And that is it for today, guys. Thank you very much for listening. Thank you for supporting PEM Rules. Please check out the website pemrules.com and check out our Facebook page. I hope you can learn from all the material there. Again, always appreciate your support. The following outro is one of my favorite songs by Lenny Kravitz. It's called Dancing Till Dawn. I recently saw him here live in Vegas. Highly recommended. Hope you have a great day. Thank you very much.